Welcome to the next episode of Lessons from the Lab. I'm Devin Rubin, and I'll be hosting this episode. The goal of this is to provide you with some practical knowledge related to the practice of EMG or neuromuscular medicine. And I will be bringing a guest in to discuss a practical case that we had in our laboratory. It's been a great day. I'm really looking forward to this. I've been looking forward to this all day today. I worked in the EMG lab. It was a challenging day. We had quite a few interesting cases, ones that caused us to scratch our head, to think about the patients, and it's a good mentally exhausting day, but a great way to end the day is to spend some time with my guest today, Dr. Michael Anderi from Michigan State University. He's an experienced electromyographer, and we always have a nice time discussing topics related to EMG. We like to banter back and forth a little bit, so I've been excited to give him some challenging questions on a fairly common case, and hopefully you'll learn something and you'll enjoy the discussion. It's a pleasure to welcome my guest, Dr. Michael Anderi. Hi, Mike. Good to see you.
How are you, Devin?
You're
Good to
up.
see you.
Are you up in Michigan at Michigan State?
At Michigan State University, I am. Yeah.
Yeah. Are you in your
I'm in my basement?
Your basement, okay.
Yeah.
Your home basement or your work basement?
My home basement, but I have worked from home quite a bit, since COVID, so.
Now, do you have an EMG machine in your basement?
I don't. I want one, but I don't have one yet.
Yeah, I'm still trying to get our institution to buy me an EMG so I can just play with it when I have nothing to do at home.
Right. Well, I have a skeleton. I play with that once in a while, but not so much
Yeah.
EMG.
Well, were you at home all day or were you working today?
No, today is Tuesday, so I did actually inpatient rounds this morning, and I will not be sticking people with needles for EMG till tomorrow morning.
Oh, okay. Okay. Well, then I can't ask you how your EMG day went today, but I had a good day. I saw lots of interesting things and made us all think hard about what we do and the techs, what they're doing.
Can I tell you what happened with me EMG? So I didn't have EMGs today. I was doing rounds. Our residents were doing an inpatient EMG, and they brought me back pictures, and the ground was broke on the machine. I was like, what? Why? I don't get this. What's happened? Yeah, I said, why don't you see if the ground is broke? Which it was. So they were in the ICU doing, an AIDP workup, and
with a bad ground.
Oh yeah, it went really bad.
So they thought, yeah, I can imagine it's bad enough doing an EMG in the ICU with a good ground.
Yeah, exactly.
Yeah, right. Well,
so I guess I didn't really do an EMG, but I impacted one.
You impacted. That's what's most important, right? As long as we're having a positive impact.
Yeah, that's right.
Well, I wanted to, the goal of this is for us to teach our viewers something about EMG and or how we approach a patient and give maybe some of your practical knowledge and wisdom to help people who are performing studies in their practice. So I thought what I would do is I'd present a case to you, a very straightforward case of a patient that we had yesterday in our laboratory. And it was and I'll just pick your brain and see what you think, and we can talk about how you would approach this patient. But the patient was a 55-year-old woman who was sent for a question of a cervical radiculopathy. And the story, her symptoms were fairly vague, but she had about 3 weeks of pain in her neck. It was her right side of her neck. And the pain kind of went down her arm. It was really vague, just kind of achiness in her arm. And she felt that she had this numbness and tingling that would sort of come and go over the 3 weeks throughout her right arm. And she couldn't really specify which fingers. It wasn't her thumb or index finger. It was really vague, as we see a lot. I don't know if you do, but lots of patients can't specify
every day.
Yeah. So the typical patient. So that was her story, and her exam, when I examined her strength was normal throughout her arm. Her reflexes were normal, although her triceps was questionably slightly reduced. She was had a bit larger body habitus, so it was maybe a little tougher to tell, but maybe slightly reduced triceps. But otherwise, her examination was normal. So
Okay,
that was it. So
that's good enough.
yeah,
So you want me to start? What am I going to do with this person?
yeah. What would you do? Like, what would in your lab, or what would you do?
So if you're my resident, the first thing I want to know, the most important reflex is the Babinski in somebody with neck pain. I would argue, okay? Just because we're going to play a game here, right? Because a decreased triceps are not going to go to, it's not cervical stenosis. But almost every month we see somebody coming from family practice or an NP, not neurology, but somebody else who misses a Babinski and they've got a cervical stenosis or myelopathy and they get missed. So you probably didn't do that though.
No, you know what? I think I need to train more with you. So I skipped the Babinski. In fact, I
Okay.
didn't even take her shoes off. But I think that's a good point. And well,
Yeah,
I mean,
that's all
certainly
right.
if there were concerns about, she had other symptoms, then yeah, obviously
Yeah.
we would do that.
She had trouble walking. I think you'd probably do that. I know you would personally, but just for the point, my point being, if you come in with neck pain, my residents, I joke, I say, even if they have an amputation, I want to know their Babinski sign, so they always get it. All right, so how do we approach that? Right? How do
Yeah.
you? Yeah. Well, so we could debate this. I don't know if you're going to do it, but I'll take a stab that might be different than yours because we do our own nerve conductions and we have residents, so I don't have techs. And I might do needles first. It's maybe 20 to 30% of the time I'll do needles first. Just thinking cervical radiculopathy is number one on my differential. Carpal tunnel, everybody's got that. Ulnar neuropathy is lower on our list. Brachial plexopathy. And this is only 3 weeks old, you said.
Mm-hmm. Yeah.
I hate that.
That's why I'm presenting this case to
Oh,
you.
you are cruel. I was paying attention to you, Devin, but the denial has gotten by me. Okay, so
So
would
let
I
me
do?
ask you, like, so
Yeah.
the three, so why do you hate it? Why do you say that? And I think we would agree, but why?
Well, there might be a lot of axon loss, and next week there might be fibrillations, but today there might not be.
Yeah. So would
And
you do when someone comes in and it's 3 weeks, do you do the EMG, or do you delay it for a week, or
this is a
like,
shared decision. So I'll look at the patient and decide how long our waiting list is and all that stuff. And sometimes I'll say you should come back in a week if their Babinskis are down going. Okay, if they
yeah.
and all things are medically equal. Okay, or I'll say, look, this could be false negative. I'll use different words than that, and say I may want you to come back in a week or so if it's normal. What do you want to do? If AIDP or some other neuropathies in the differential, I might do the nerve conductions and have them come back for the needle. If I can persuade myself that carpal tunnels, I know carpal tunnel's low on this, but I would argue people get ticks and fleas all the time, so you could see carpal tunnel. So we could do the nerve conductions and then bring them back for the needle EMG. And I'll give you one more scenario. If they're really weak, which you said they were not, but I might do recruitment in some of the C7 muscles and see if that looks neuropathic.
Mm-hmm.
But if the strength is really strong, my view is I probably won't find that.
So
What do you think?
So let me I want to continue this conversation, particularly with the needle exam. But before we can, I'm going to pause before we continue with this, and I want to just show you so our techs did the conduction studies first. So we have techs, they do it, and I would agree with you. I would think, if you're going to throw one part of the test out, the conductions probably aren't that helpful in this situation, unless you're looking or you have a suspicion for carpal tunnel syndrome, which we didn't have a big suspicion. But I'm just going to show you real quickly here. I'm going to share my screen if this will work. And I'm not going to ask you about this, but I'm just going to show you. Can you see this?
Okay, yeah,
So basically,
good.
this is a little bit small, but so what we did is we did a median and ulnar motor, and they chose to do the median and ulnar orthodromic studies because I guess they were thinking maybe this could be carpal tunnel, and for our lab, these were all basically normal. I think that the orthodromic latency was just kind of borderline relatively prolonged compared to the ulnar, which I didn't think was too significant
Oh,
given
so
that,
you did your orthodromic at the elbow. Okay.
yeah, we stimulate the wrist, we stimulate palm and record wrist and elbow to get a velocity.
Oh, cool.
But the point being is not, and you're welcome to comment if you want, but it's not to scrutinize the nerve conductions as much as they were essentially normal for her symptoms, maybe a smidge of, like you said, a tick and a flea of carpal tunnel, but not related to the neck
Yeah.
pain and symptoms. So
So I'd agree with the carpal tunnel, right? Your ulnar is 1.7 and your median is 2.2. So that's a difference of 0.5. That would be borderline abnormal in our lab. Like, really, right. Not explaining neck and periscapular pain. Agreed.
yeah. So would you do,
Oh,
so if you do, so I guess another point is, when we see patients that we think maybe have a C6 or C7 radic, do you do other nerve conductions? Because these don't really test those roots.
okay. So I get more question about waking up with numb hands and that, but I might hunt down the carpal tunnel. I might do D1, D2, D5, or D4. I might. It depends on the patient and what they said to me. I don't think I would do other ulnar nerve. I like getting a radial, so I like a D1 because plexopathy is still in your differential, and I'm a little compulsive and I have resonance. So, and an atypical polyneuropathy, would you say 55-year-old, So, yeah, rarely would I only do this much. I would probably chase down that 0.5 a little bit more depending on the patient.
Okay. And I guess also the point for the viewers is let's say that the Palmers were totally normal and they were the latencies were the same. That when we're assessing, at least I feel this way, when we're assessing for C6 or C7 RIC, we don't have any nerve conductions that really help us. I mean, you can do a radial motor or you could do a musculocutaneous or axillary to the deltoid, but the yield, I think, of those is so low unless there's a severe radic with severe axonal loss. So we don't do those more proximal motor conduction studies for radics.
Agreed.
Yeah. Okay.
Yeah, they hurt too much. They don't give you a lot of data, and if you don't find it on the needle, and I guess the other reason to do other tests is not so much to find radic as to find other stuff that's mimicking it. But
yeah,
so a snap amplitude for the radial, like the thumb, radial and median of the thumb might be of value. The LAC might be, but no, I routinely would not do that.
So if I'm understanding, if I'm putting words into your mouth, then the need for a radic assessment, a mild radic assessment, the needle exam is going to be more useful than nerve conductions. And that's why you said at the beginning you might do the needle exam first because you're more suspicious. Yeah.
Correct. Yeah, and time and money, blah blah blah.
Yeah.
Yes.
So let's go back to the needle exam. So we were talking about 3 weeks, and you would discuss that with the patient and decide what to do. What about if it was 2 weeks? Would you still do that, or would you would you?
Is it really 2 weeks? I probably would send them out, depending on the psychosocial factors. I might needle just the paraspinals. If they're going to go to a surgeon and they're coming from a surgeon, and the surgeon wants it, then I would be more apt to go after it. Say it's negative. It could be false negative. I will say this. I don't know if you agree, but I've seen I'm going to use the word frequently, so I don't have to be exact. But it's not rare that I will find fibrillations or a whole bunch of insertional activity in a pretty big radiculopathy at 2 to 3 weeks. So that gives me a pretty strong clue. If they're getting lined up for surgery or MRI or they're weak, that would matter. This case, you're basically giving me a normal exam. So I think it's going to be subtle. I don't want to torture the patient. So unless the patient begs for the needle, I would have them come back, usually.
Yeah. And
How's
I
that?
get, yeah, no, and I think your point, we have this, we teach and we have this magic number that 3 weeks is the magic timing of the fibrillations. But I think what you're saying, and I agree that they can occur earlier than that. They could occur, and part of it, I've always thought, and I think there's evidence that it partially depends on the distance between where the axon's been damaged in the muscle.
Agreed.
That's
why
yeah.
I would do the paraspinals, and I might do the deltoid or some of the more proximal muscles if I thought it was a ridic. Yeah. And previously, I have seen, and I'm sure you've seen too, if you've done it, where I had a normal study at 3 weeks, a week later, it had fibs out the wazoo. Same disease. And,
So,
the question is always, when did it start? Most of the time, so here's somebody who's got vague pain in their hand, and they're really going to tell you exactly when it started. I mean, they'll say, well, yeah, it started. What about 2 weeks ago? Or what about 2 months ago? Well, it didn't hurt that much then. So if they give me that story, then I'll do the needles.
Yeah.
But if it's truly, I was out, I was running a marathon, I fell on my head 3 weeks ago today, then I wouldn't. But almost always I can convince myself they had some symptoms before that.
Yeah. Now, since you're a really smart guy, I'm going to ask you a tough question. How many fibs would be enough to say that it's abnormal? If you have 2 fibs in a 3-week symptom onset, you have 1 fib in one spot and 1 fib in another. Are you going to call that abnormal?
Well, you're just totally baiting me. I can tell. So we've had discussions about this over beers. So so I'm really trying to figure this out. And I know that this is not science, in my opinion, but I'm giving you my opinion. This is how, because my residents say, well, how many fibs are there? All right. So here's what I would say. If it's between 300 milliseconds and 3 seconds, sometimes I'll weasel the 2, then I'm calling that increased insertional activity. If it lasts between 3 seconds and 10 seconds, that's 1 run. Not 1 plus, 1 run. If I have 2 runs, then I call it 1 plus. So that would be 2 separate insertions, and that thing would have to go pop, 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 pop. That's 1 run, not 1 plus.
Mm-hmm.
Okay, we could debate this. I mean, Devin, this is so, like, you're right down to the nitty gritty, right? And we've discussed this a little bit. If it goes pop, 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 and lasts 15 seconds, then I'm calling that 1 plus. In my opinion, that's reproducible. As long as it's clearly a sharp wave, it's not anything else. I can drink my coffee. I can look at it. I can say to the residents, what else could that be? Then I'm done torturing the patient, and I'll take the needle out. That'll be 1 plus. Okay. And I think it's unusual for a 55-year-old to have fibrillations that last that long. So then 2 plus and 3 plus are bigger than that. How does that sound?
Well, I think it's an interesting thought and discussion. I think a couple things. One is increased insertional activity in a 3-week-old radic, and means that there's irritability. And I think what I would say in that situation in my report is the findings are minimal and isolated to increased insertional activity, which could be seen with a very early process involving that root. Would you? I
would exactly say that. Yeah.
Yeah.
What I want to do is, if I see that, especially if I see, 2.5 seconds of insertional activity, at 4 or 5 places in the same muscle, oh yeah, I'm biting on that. Like I would even write, this will probably turn into fibrillations in, a week or 2 weeks or whatever I decide.
Yeah.
I don't think go.
And I think that the grading of the fibs, we would do that somewhat different. And, my feeling is, regardless of how long a spike fires, whether it's, let's say, over 3 seconds, I agree 2 to 3 seconds would be an increased insertional, but let's say it's 4 seconds versus 15. If it's the same spike, I agree it's a fibrillation, but it's one muscle fiber that's been denervated that's firing. So to me, one
Oh,
muscle fiber that's firing for 15 seconds is still one fiber that's denervated, and
okay.
versus moving the needle to different areas and having more than one muscle fiber that is firing. So more than one fibrillation, that's where we would call it 1+. If we have definite fibrillation in at least 2 areas of the muscle. So
I think that's really defensible, and you have never told me that argument before, and I like it. I have to rethink it
I've
because
been
I really
saving it
don't
for this
know.
discussion.
Just to make me look stupid. I admire that.
No, no, it's, and it gets into the why do fibrillations persist, and that gets much more technical than I think we want to get into here. But yeah, I think the density, our grading is more based on the density and kind of reflects perhaps severity of the fibrillations or the severity or extent of denervation rather than the persistence of the denervation.
Okay, I see both. I don't know what's right or wrong, but I think that's a defensible position. So your point would be, and I see that you have one denervated myocyte, and if I just look at the same denervated myocyte, that person could be normal. Where you're saying if there's at least 2 of those, it's more likely to be abnormal, and I would probably agree with that.
Yeah, and I think the harder question, follow-up question to that is if there's just one. I remember as a resident discussing this with one of my mentors, and what the discussion was, can you blow off one fibrillation? But then the argument is, if there's a fibrillation, there's a denervated fiber. Right. So you
We
should
agree.
not
I
have a
agree with that.
fibrillation. So it's a denervated fiber. Now, does that mean that there's root damage? And is it enough to call? I think we would probably all agree we're less comfortable if we just have a single fib versus having several fibrillations or several spots of increased insertional like you were describing.
Yeah. So can I tell you how I often handle that? Let's say it's this guy, this person, they're 5 weeks out, and they have one clear fibrillation, my 15 to 20-second fibrillation in the tricep. Okay? So it's probably in C7, and they say they have numbness in their little finger, and they have a little bit of weakness somewhere else, just to prove it. So I will say there's one electrodiagnostic finding, highly suggestive, but not clearly diagnostic for a right C7 radiculopathy with very little axon loss. I might interpret it that way, or I might say of unclear significance. I don't believe it.
Yeah, and I'll do something similar. I might word it almost like the flip and say, and this gets into the point that we're clinicians and we're using our clinical judgment as well, rather than just simply performing a test. But I might say, while there's not definite evidence of a radiculopathy, the minimal changes in the triceps in the context of the patient's symptoms could be due to a very mild or early process involving the root.
Yeah.
So I might hedge, but hedge pointing the referring physician in the direction that this is what I'm thinking. I think this could be significant, but I'm not sure.
I would do virtually the same thing. I will also say, if I'm on the fence or if I think I'm at risk of overinterpreting, like nerve conductions and stuff like that for neuropathies and that, I might say, I'll say some labs would call this normal. And I just put it out there so that they know that I'm maybe pushing the envelope on interpretation. It might be wrong.
Yeah.
Yeah.
Right. No, I think these are tough, these are tough cases. And I think the last point to the last question, and you mentioned this, and I do want to mention it, if it's been 3 weeks, we may or may not start to see increased insertional activity or fibs. But you mentioned recruitment, and if the patient, if they have an acute radiculopathy that's sufficient to block some of the conduction, then recruitment, you might see reduced recruitment in those
They're
muscles.
really weak. Yes, agreed. You've seen that before.
So like in the, right, yeah. So like in this, I'm going to show this just my only other slide, in this patient from the triceps, and this is at a long sweep of a 1 second sweep, and hopefully you'll be able to hear this. I may have not hit the sound button. Can you hear that?
I cannot.
No, I forgot to hit the Zoom sound button. But the point of this, without hearing it, is these couple motor units are firing at about 20 hertz, and the morphology was actually pretty good, pretty normal. So there was reduced recruitment in the patient, in the pronator teres, and slightly in the triceps also. So do you look at that? Do you do you care about recruitment?
No, I think
No?
recruitment. I'm exaggerating. In this case, I would look at recruitment, and I would probably agree that looks like it's probably decreased recruitment. But I use monopolars, and you use concentrics, I believe.
Right, but does that matter for recruitment?
Oh, I do. I think it does. So my view would be, just baiting me. I love you. The science behind it, I think, is not so great. But that you don't see as many motor units with, at least I do when I use a concentric, because I use both. And it's way easier for me to find 20 hertz motor units that fire at 20 hertz with a concentric needle than it is with a monopolar. And I think because you just see more motor units, because the concentric, you get 180 degrees, whereas with a monopolar, you get 360 degrees. So that's an opinion, though.
So I wanna have a bet with you.
Okay. A beer bet. Beer bet.
A beer bet. I'd like you to send me a clip of an EMG clip of 20 hertz in a normal patient that's not a facial muscle. Because I don't think you can fire at 20 hertz in a normal muscle.
And find it.
I don't think so. I mean,
and find it. You know that normal motor units fire at 20 hertz all the time, but you can't find it.
Because they don't fire at that rate without having at least 10 motor units firing.
Agreed. Okay.
And it's hard to identify when you have 10. For me, it'd be hard to identify a unique motor unit with 10 motor units firing, filling the baseline.
I think I see it at 20 hertz, and I'm just taking the fastest guy. Yeah, but okay, that is a fair challenge, and I gotta say, just at the AANEM meeting last month, Sanjeev Nandekar convinced me that I'm using 20 and I should be using 16 or 17 hertz. That I'm missing some case, and I agree, I'm missing cases.
Well, no, I agree, and I think we're going to have another recording and talk about recruitment. We could do this for an hour. I present a whole session at AANEM on motor unit recruitment, and I think the mild recruitment, that cutoff of how fast a motor unit fires for mild reduced recruitment hasn't been as well defined, and I would agree completely. I think in very mild reduced recruitment, and I'm actually looking at this, if you have a motor unit that's firing at somewhere between 12 to 14 hertz before a second motor unit comes in, so minimal effort in most muscles, not all muscles, that's probably mildly reduced recruitment. So I think that bar drops even lower. I think, and that's why I said, I think if you're identifying motor units at 20 hertz, there's already moderately to severe reduced recruitment.
I would say that's almost, you and I agree with that, with a monopolar, but with a concentric, I think not. But you're going to disagree with me, so we have a bet. I don't use my concentrics all that much because most of what I'm just doing single fiber. So I will, but
the concentric
out, I like that.
Well, no, I mean, you're right. The concentric needle is going to have a smaller pickup area, but it's not, I don't think it's substantially smaller that you're not going to still pick up the nearby motor units. They may be a little bit smaller in amplitude because they're a little more distant, but they're still firing. And so I don't know that there's a substantial difference in unless you have such strict criteria of amplitude of the motor unit or rise time of the motor unit that you're including when you're assessing recruitment, I'm not so sure that there would be such a big difference in the number of motor units that the needle is recording.
I see your point. I understand that, and I'm not sure that I agree with it, but I can't disprove you. All I can say is what I think I've seen is that normal people with 20 hertz motor units, I find that way more frequently with a concentric than with a monopolar. So at the end of the day, our bet is that I'm going to find something in a person that's normal. Like I could send you a fake one, but we wouldn't. That's like there's sport in that. And my residents will haunt me on this. Like they'll like
so
they
we have till next November when the AANEM meeting is to find cases like that, find examples, and we'll sit down at AANEM and we can sit in front of an audience and we can debate our clips.
Oh man, you're crushing me. Okay, yeah, that would be kind of fun.
Or we could just sit at it and have a beer together and debate our clips.
Yeah. Oh yeah, I'm okay. I think our field is not scientific enough in recruitment, and the only way it's going to get scientific is if we, number one, talk about it, look at what we're doing, and then do some science. And I would, at least from what I've seen out of the younger generation, I'm going to call you, you're far and away. Your teaching is phenomenal. Like I go and I listen and I go, man, you're good at it. So, and you're making the difference with all of our young electromographers. I mean, they really like it, and I have tremendous respect. So when you talk, I do listen. I don't agree, but I do listen.
But I think you're right. These are good points we're using data that's old data, decades old, and it is important to redefine the data, particularly when it comes to these reference values and reference data, not just for nerve conductions, but for needle exam and even size of motor unit potentials. Most of that data is old from many years ago, and so
last century, right?
Yeah, so I think there's much more that could be done. I agree with you completely that to fine tune what we're doing.
Yeah.
So
and I'm totally game for it. I mean, it's fun.
Yeah. Well, this has been great. So I think that the take home points of this case, let's make sure we agree on these, is that from what I'm hearing, we can perform an EMG in a 3-week-old patient sent for Radic, but with caution and with the caveats that we may not be able to identify definite abnormalities and may want to repeat the study.
Agreed.
2, fibrillations or increased insertional activity might be identified even earlier than 3 weeks, maybe 2 to 3 weeks, and particularly in the paraspinal. So we always want to examine those if we can in that time frame.
Agreed.
And number 3, to always perform a Babinski sign in patients with neck pain.
Yes.
Well, those are great points, and I hope the audience will remember them. And I really appreciate you taking the time to do this and for us to chat and teach our viewers some practical knowledge from a very experienced and seasoned electromyographer. So thank you.
It's an honor, Devin. Great to talk to you, and we'll see you at the next meeting.
All right, sounds good. Well, I hope you enjoyed that lessons from the lab. It was a great time, as I expected, with Dr. Anderi. And as we discussed at the end of the interview, there are some important teaching points that I think are related to what seems to be a fairly simple case. We see lots of patients that are sent for an EMG for radiculopathy, and sometimes it's obvious whether they have it or not, but in certain instances, such as this case, it wasn't very obvious. And particularly when patients have mild symptoms or have very early symptoms, we may not see much on the EMG. And I think what I always think about and what we discussed is that the nerve conduction studies are not very helpful in most radiculopathies unless it's more severe or unless we're performing them to exclude an alternative diagnosis such as carpal tunnel or median neuropathy at the wrist or an ulnar neuropathy. So they are important to perform, but if we're solely looking for a radiculopathy, they're probably the least sensitive study. The other important point that comes up often in our lab is the timing of performing the study. And as Dr. Anderi mentioned, sometimes patients say they have only had symptoms for 3 weeks, but then if you ask them further, they say, well, you know what, come to think of it, I actually have had symptoms on and off for a longer period of time. And the likelihood, in my experience, is that in those situations, we may identify changes more often than not, or compared to a patient who says, I only have had symptoms for 3 weeks. The other point is that even if they've only had symptoms for 3 or 4 weeks, we still may be able to identify subtle abnormalities. But it's important to pay attention to the subtleties and not rush through the study. And sometimes those fibrillations in the paraspinals are in the deeper layers of the muscle, or you have to move the needle to different segments or sections of the muscle to identify them. So it's not always a cursory examination that will identify the abnormalities. The other point is pay attention to recruitment. We have some disagreements about recruitment, but I do think we agree that in early neurogenic processes, such as an early radiculopathy that's severe enough to knock out or damage several axons, recruitment may be the only abnormality. And so it's important to pay attention to reduced recruitment to determine or not overlook a mild or early radiculopathy. So I think those are useful points to think about. They're practical points, and hopefully you'll remember those as you're examining patients that are sent to your laboratory. Thank you for tuning in and look forward to next time. Bye-bye.